let's discuss an important pathophysiology, why polycythemia occurs in COPD patients. So, what is COPD? COPD is actually chronic obstructive pulmonary disease. That means the patients are suffering from chronic airflow limitation. That means the patient will breathe in, but he will not get proper space to breathe out because of the obstructive airway disease. Now, this chronic airflow limitation in which the patient is breathing in, but he is not getting the proper ways to breathe out, this will cause accumulation of more and more CO2. Hence, the ventilation will not be proper, and this will lead to ventilation perfusion mismatch. That means the ventilation is not going proper, but the perfusion is also not getting proper. So this will lead to ventilation perfusion mismatch. Now, what will happen when this ventilation perfusion mismatch will occur? The oxygen will not reach to the periphery of the lungs. Hence, the tissues and the periphery of the tissues. Hence, the tissues will not receive proper oxygenation, and there might be cyanosis with which the patient is suffering because of this VQ mismatch. So, this will lead to chronic hypoxemia. That means when you do the ABG of this patient, there will be decrease in the PaO2 levels. Now, what will happen because of this chronic hypoxemia? The oxygen are not reaching to the peripheral tissues. So, now the kidneys will get stimulated. And these kidneys, the kidneys will get stimulated. Now the kidneys will feel that if the oxygen is not reaching to the peripheral tissue, that means the body is not having enough of RBCs. So the kidneys detect this low oxygen tension and they think that RBCs are the main culprit behind this. So the kidneys will give order to erythropoietin that you should increase your supply so that you will increase the production of RBCs. So there will be increase in the erythropoietin levels. Now, when the kidneys detect this low oxygen tension and rise in the erythropoietin levels, there will be stimulation of the bone marrow. And once this bone marrow gets stimulated, it will cause more and more production of RBCs. This will ultimately cause increase in the hemoglobin levels and increase in the hematocrit levels. So, the entire pathophysiology is moving towards rising in the level of erythropoietin, stimulation of the bone marrow, increase in the RBC production, increase in the hemoglobin, and this is called as secondary polycythemia. Now, once the kidney has done all these things, will the issue of chronic hypoxemia will be resolved? The answer is no, because there was no defect in RBCs previously also, there was no defect in erythropoietin previously also, but the defect was in the oxygen ventilation supply. The oxygen is not reaching to the peripheral tissues because it is not getting a proper pathway to go. Hence, this secondary polycythemia will not resolve the issue of chronic hypoxemia, but in return, it will cause its secondary complications, like it will cause increase in the blood viscosity levels. This will ultimately cause pulmonary hypertension or pulmonale, and patient might land up into thrombosis. Hence, you should know this thing that polycythemia in COPD patients who are chronically hypoxemic, if you do not treat the proper condition, the patient may land up into pulmonary embolism, and thrombosis is one of the common reasons for polycythemia. So the next question comes, how to treat these patients? So before that, how will you define polycythemia? So if the hemoglobin levels is more than 16.5 gram per deciliter in women or more than 18.5 gram per deciliter in men, or and the hematocrit levels are more than 48% in women and more than 52% in males, this is defined as polycythemia. So now, how will you treat these patients? What are the causes of these polycythemia? Who are the patients who will get polycythemia? So advanced stages of COPD, chronic hypoxemic patients who have PaO2 levels less than 55 to 60 mmHg on their ABGs are risk factors for polycythemia. So how will you treat these patients of polycythemia? So chronic hypoxemic patients of COPD who are suffering from polycythemia should be treated with LTOT at home. That means these patients are a candidate for long-term oxygen therapy at home. What do you mean by long-term oxygen therapy? Long-term oxygen therapy means these patients will need oxygen supply at home through nasal prongs at least for 15 to 18 hours per day. That is defined as long-term oxygen therapy at home. And these patients who are chronically hypoxemic with polycythemia with PaO2 less than 55 to 60 mmHg are candidates for long-term oxygen therapy home. LTOT will cause correction of chronic hypoxemia which will ultimately cause decrease in the erythropoietin production. There will be decrease in RBC productions, and gradually this will improve the issues of secondary polycythemia. Hence, it is very important to know the pathophysiology behind the primary cause and treat it accordingly.